Thank you very much indeed. And first of all, I thought I should explain ourselves, because you might be thinking, what on earth is NICE doing getting involved in research when we're well known to be actually an independent organisation responsible for producing NICE guidance. And generally, that's about cost effectiveness of technologies. But we do also run the Interventional Procedures Programme, which is responsible for looking at the efficacy and safety of new procedures or established procedures where a safety concern is expressed, which is exactly what happened. And when we are referred a procedure like this, we often have to use more than just published literature. Often it's very early in the development of a technology. So we look at patient experience and clinical practice as well. Hence, clinical practice being relevant to our audit. So back in 2009, when we were asked to look at this procedure, the literature was limited, as has been said. We looked at a total literature base of relating to over 1,000 patients, but only one RCT and lots of case studies. So our advisory committee, which is made up of surgeons, lay people, manufacturers, actually concluded that the evidence on the efficacy and safety of this procedure was not adequate. However, they did conclude that it wasn't clear whether NPWT was the cause of fistulae, and they recommended that the technology should only be used if special arrangements were made. And that means telling the hospital about telling the clinical governance of the hospital that the technology is being used, collecting data, and also informing patients. Now, we completely understand that will be difficult under this situation, but that is what we normally mean by special arrangements. And we recognise that back in 2009, there was no way that this audit data could be collected nationally. And NICE, in that situation, has a remit to organise a national audit, or a national survey, you might say. Now, it wouldn't be good enough just to collect data on NPWT, so we needed to set up an audit that collected data on all patients who underwent management of the open abdomen. And we established this audit to run between the 1st of January 2010 to the 30th of June 2011, and actually kept the portal open until 6 months afterwards in order to gather data for as long as we could. We wanted to exclude any patients where the wound broke down without the actual bowel being exposed, and this was quite a point of difficulty because people out there rang often to say, what is your diagnosis? Please define who should be included in this audit. But eventually the message got across, and we produced a data collection sheet which was put on the Aberdeen University portal. And this was complicated, but it really was necessary to be complicated in order to catch all the possible underlying factors that might lead to the formation of fistulae. This is what it looked like. There was the web version as well. And in fact, sort of halfway through the audit, we discovered that it was, even after our great efforts to be simple, there were some points that were absolutely essential, and we helped people by identifying them in blue and saying, even if you just send in this data, we'll be really grateful. So the portal was available there and completely independently run. You know, we wanted to make sure that we got all patients. We worked with ICNARC to identify hospitals with ICU or HDU units because we felt that's where patients would be managed. So if patients were managed on general wards, we wouldn't necessarily pick them up, although we think that hospitals with ICUs and HDUs would be the ones looking after these patients. And here you are. This is how we got on. So we contacted 269 hospitals in Ireland, Northern Ireland, Scotland, Wales, and England, and we asked them to register somebody. If they didn't respond and register, we mercilessly chased them to register. And 105 of the 231 hospitals that registered actually sent patients in. Simultaneously, we were working with ICNARC, and they were using 2 data sources to identify patients that should be submitted to this survey or this audit. And so there was quite a lot of active surveillance going on. We were having monthly meetings to make sure that patients were being sent in. And we received data for 717 patients. Interestingly, that ranged from anywhere between naught, so some hospitals weren't sending any, but of the hospitals who were sending in patients, most were sending in one, and a maximum, the one hospital actually sent in 53, and it wasn't a particularly specialist hospital, so it's quite interesting. The median being 3, yes. So 717 patients, that's very exciting, but actually when you look at the data, we had to remove quite a few of these patients. 15 of them were duplicates, so these are patients who'd been started on open abdomen management in one hospital and then transferred to the other, and we identified them and removed the duplicate. 100 of them actually, there was this problem with definition, and it couldn't be confirmed that they genuinely had an open abdomen. And then some of the 13, the information was just too poor to actually decide whether these were true open abdomens. This left us with 589, and then we spotted that actually 11 of them were under the age of 12, and we decided that these would be a special group, and perhaps we should publish that series another time, but we've removed them from this series. So that left us with 578 patients for that 18-month period. And the majority, 59 years was the mean age of the patients. A greater proportion of them were male by a small amount, and the majority of them were done as a result of an emergency laparotomy procedure. Now, interestingly, in our UK series, 69% related to severe abdominal infection, which is very different from the American experience, where trauma is the most common underlying reason to manage the open abdomen, and I'm sure colleagues will talk about that later. And so what are we using in the UK? Well, 61% of patients were managed with the negative pressure wound therapy, and 88% of those were the commercially available systems, mainly the KTAI one, but others have become available since. And most of them use continuous negative air pressure. And 77% used a non-adherent sheet. Now, 23% therefore are not being managed using a non-adherent sheet, which is against company guidelines. I'm sure we'll come back to discuss that, because that's an important point. So what alternative techniques were used? The Bogota bag was much the most common, and I can tell you, after the first couple of lectures, we had no Whitman patches in this series. Prosthetic mesh was the next most common. And then there were several, in this others category, it looks quite a big category, so I'll just tell you a bit about them. The packing was the most common, and then quite a lot of text was given to us where it would be difficult to define exactly which category they fit into, but we will explore that a bit further in the paper. So here's a simple analysis of outcomes, and then my colleague Graham is going to explain, because actually the simple analysis is not good enough at all. If negative pressure wound therapy is used, at first glance it appears that patients are likely to require less intervention to control bleeding, but they will require more TPN for more than 28 days. That's first reading. Delayed primary closure seems to be much less frequently done in the group that had negative pressure wound therapy. Death, slightly less common in the group where NPWT were used. And intestinal fistula, which was what we were actually looking at, seemed at first glance to be more common in those in whom negative pressure wound therapy was used. And I'm going to hand over to Graham, who's going to explain how we should analyse this in order to really interpret the data.
Hello everyone. Thanks for inviting a statistician into your midst. And I have to say, in the whole time I've been involved with this project, I've managed to avoid an image of the open abdomen, and that first talk has left me quite traumatised. hopefully I can get my own back on the rest of you just now. So, how can we interpret this data? Obviously, this is observational data. It's not come from a randomized controlled trial. And really, we can't draw any inference about cause and effect because there is the potential for baseline imbalance on prognostic covariates, and that's due to selection bias. So what do I mean by that? Well, selection bias is when you as the treating surgeon might say, well, this patient's not suitable for negative pressure wound therapy, we'll use a mesh or a bag or some other alternative. So selection bias can be related to the treatment that's received and also the outcome. And we know from observational research that treatment effects are usually biased in one direction or the other and not directly comparable with that from randomized studies. And in this cohort, the people that got negative pressure wound therapy were more likely to be younger, they were more likely to be male, to have had an enterostomy and to be managed in a high volume center, and also to have had previous abdominal surgery in that admission. So how can we correct for that, make some sort of adjustment to infer cause and effect? One method is to use what's called a propensity score analysis. So what we do is we use a logistic regression to try and predict who would receive negative pressure wound therapy or some other form of management given their baseline covariates. Now, in a case series or an audit like this, if there was no selection bias, then the distribution of probabilities of receiving either treatment should be the same, and that's what you would get in a randomized controlled trial because everybody's got a 50-50 chance of receiving the treatment regardless of what their baseline covariates are. So, a quick graph. Hopefully you find this image as hideous as I did the open abdomen. This is a graph of the probabilities of the two groups of receiving of not receiving negative pressure wound therapy. The red line is the other management group, and the blue line is the negative pressure group. And you'll see that those lines don't sit on top of each other, and actually this is evidence of selection bias. The group that, and this probably sounds like a tautology, but the group that received a different form of management are actually more likely to receive that based on their baseline covariates. Okay? And the covariates that we used were things like age, gender, the center they were in, the diagnosis they had. I can provide more details on that if people are interested. So that was evidence of selection bias. So where did the selection bias exist as an aside? Well, one way to assess that is not using statistical tests because that relies on sample size, and we have quite a big sample size here, so we would find significant differences even if they were quite small. One way to do it is to look at what's called the standardized mean difference between the two groups on the baseline covariates. So what we do is, say for age, which is the fourth category, we would take the difference between the ages and divide it by the standard pooled deviation to give us an estimate of the proportion of difference that exists between the two groups at baseline. So, in the statistical literature, a 10% difference is considered a baseline imbalance. And so along the x-axis here, it runs from 0 up to 20%. The blue line is the differences between the groups, standardized differences between the groups. And you see that for all of these covariates, it was greater than 10%. Further evidence that there was imbalance between these groups at baseline on important prognostic covariates. The red lines are the imbalances after we corrected for them by matching. So the process is you run a logistic regression, you derive the probability of receiving one or other of the treatments, and then you match people together. So you're trying to get like with like so that you get two groups of people that are not imbalanced at baseline on the covariates. And the red bars are those numbers after matching. So you see that we've got a group that has reduced baseline imbalance. And just quickly, this is the distribution of the propensity scores in the whole cohort, and then this is the distribution of the propensity scored in the matched pairs cohort. So what we've done is we've tried to match people who received negative pressure wound therapy with a similar person who didn't get negative pressure wound therapy. So we're trying to recreate a randomized trial, as you were, from the observational data. So the outcomes, it's quite a busy slide. I think I'll just go straight to the last two lines, which are in bold. There was a slightly reduced death rate in the negative pressure wound therapy group. So these are expressed, the risk ratio of greater than 1 means that that outcome was more prevalent in the non-negative pressure wound therapy group. So slightly higher risk of death in the non-negative pressure wound therapy group, but quite a wide confidence interval. And fistulation, slightly lower risk of fistulation in the no negative pressure wound therapy group. That's a risk ratio of 0.86. The confidence interval runs from 0.48 to 1.53. In reality, that translates into a 2% difference, an absolute risk reduction of 2%. So they're quite similar. That confidence interval rules out a difference of plus or minus 10% in absolute terms in either direction. So we'd consider the fistulation rate to actually be quite similar in these two groups. So, in summary, the audit included 578 patients. 61% were managed using negative pressure wound therapy. 88% of those were commercial kits, and 77% were used with a non-adherent sheet. 69% had severe abdominal infection, 47% of which was related to complications of previous surgery. Negative pressure wound therapy cases were 21% less likely to have their abdomen closed by delayed primary closure, and overall 28% of people died. There was no increased risk from using negative pressure wound therapy. With respect to fistulation, 12% of patients with an open abdomen developed fistulae, and the majority of those were during the treatment, not after. And negative pressure wound therapy did not make fistulation more likely.
Okay.